Hi everyone, my name's MedToMed. This video is going to be about PBC, primary biliary cholangitis. You may hear it being referred to as primary biliary cirrhosis, so just be aware that these are the same thing. These notes are based on the following resources. More recently, I've been using Zero to Finals, a really helpful book that has very concise notes, as does scotsnotes.co.uk. As always, I use the Oxford Handbook of Clinical Medicine and utilise the NICE guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. Primary biliary cholangitis is an autoimmune condition. We have these small bile ducts in the liver. You can see this duct labelled on the diagram as the canal of Herring. These are also called interlobar ducts. When the immune system attacks these ducts, granulomatous inflammation occurs and bile flow becomes obstructed. Usually, bile acids, bilirubin and cholesterol is excreted through these bile ducts into the intestine, but obviously if this backs up, you're going to get a build-up in the blood. Where there is raised bile, patients may complain of itching or pruritus. Where there is raised bilirubin, patients become jaundiced. And where there is raised cholesterol, patients develop little cholesterol deposits on the skin called xanthelasma or xanthoma. Here's a clear example of the yellow-tinged skin seen in a patient with jaundice. Remember, this is due to excess bilirubin. Here you can see xanthelasma on the left and xanthoma on the right. Xanthelasma are around the eyes, but xanthoma are large nodular deposits that occur in the skin or tendons. They are also seen in cardiovascular diseases because of the raised cholesterol levels. Symptoms like fatigue may precede the other more obvious symptoms for many years. Patients may become itchy, that's pruritus, develop GI disturbances. They may become jaundiced and have these pale, greasy stools. Naturally, bile is normally a greenish yellow colour, but as it travels through the digestive system, it turns brown, which is why our stools are brown. But if bile cannot reach the digestive system due to this interlobular blockage, then the stools are lighter in colour. We've spoken about xanthoma and xanthelasma already due to the high cholesterol, and the patients may also have signs of cirrhosis and failure such as ascites, splenomegaly and spider nevi. Vitamin D levels are low due to impaired synthesis by the liver, so this leads to osteoporosis and osteomalacia. And due to poor vitamin absorption, particularly vitamin K, this will result in impaired abilities to coagulate blood. Typically, these patients are women around the age of 50 years old and tend to have other autoimmune diseases like thyroid disease or celiac. They may also have rheumatoid conditions like rheumatoid arthritis or Sjögren's disease. What investigations might you do? Well, first, you take a look at the LFTs, which will show a raised ALP level in early disease, and as it progresses, the liver enzymes and bilirubin will become more and more deranged. Because it is an autoimmune condition, when you test for autoantibodies, you may find that anti-mitochondrial antibodies are present. This is the most specific antibody test to PBC and is therefore part of the diagnostic criteria. But anti-nuclear antibodies are also found in about 35% of patients. You may also notice a raised ESR level and a raised IgM. We do an ultrasound in order to rule out whether the bile blockage is from something outside of the liver or something inside, like in this condition. Then, in order to complete the diagnosis and stage the illness, we do a biopsy, which looks for granulomas around the bile ducts as well as cirrhosis. When we're thinking about treatment, we can treat the symptoms like pruritus, so that's itchy skin, by giving cholestyramine. This works by binding to bile acids and preventing gut absorption, So this is lowering the bile acid levels in the blood, which we know is what causes the itching. Then we can give ursodeoxycholic acid, which reduces intestinal absorption of cholesterol and can prevent heart disease. Codeine phosphate can be given for diarrhea. You may need to think about a liver transplant in the end stages of the disease and possibly immunosuppression with steroids in some patients. As the disease progresses, you should be regularly checking the LFTs in these patients. They can advance to liver cirrhosis or portal hypertension. They may also complain of their symptoms getting worse. There's a renal condition called distal renal tubular acidosis, and it's caused by autoimmune diseases. The mechanism of this condition developing is quite complex and involves a lot of biochemical explanations, so just understanding there is a complication of a PBC, that should be sufficient in your knowledge. Again, hypothyroidism can be an autoimmune disorder, and you'll find that with autoimmune conditions they coexist with each other. We've spoken about poor vitamin absorption, so again this will lead to osteoporosis. And lastly, cirrhotic PBC patients are at risk of developing hepatocellular carcinomas. This is relatively rare, but because it's an aggressive tumour, we need to be really aware of this possible complication. Let's go over what we've just learnt. We now know that primary biliary cholangitis is an autoimmune disorder that causes intrahepatic bile duct destruction. Symptoms are related to increased bile, bilirubin, and cholesterol due to their blocked entry into the gut. You may see signs and symptoms like jaundice, pruritus, xanthelasma, and cirrhotic features. This condition occurs more commonly in 50-year-old women with pre-existing autoimmune conditions. Alkaline phosphatase and antimitochondrial antibodies are the main specific tests for PBC, but diagnosis is confirmed by a biopsy showing granulomas and possibly cirrhotic features. Treat with cholestyramine for pruritus and ursodeoxycholic acid for hypercholesterolemia, but liver transplant may be necessary in advanced cases. We should be aware of the complications of this disease, such as distal renal tubular acidosis, thyroid disease, osteoporosis, and hepatocellular carcinoma. Thank you for listening and happy studying.